working fine, sir. Everything is working fine. So, sir, Dr. Nave, in the next 3 minutes, we can start going live. Bansal, sir, we have checked everyone's slideshow and everything is working fine, sir. So we are good to go live.
Okay, perfect.
Yes, sir.
Uh,
Yes, sir. So we can close the slideshow, tech team.
Okay. I've stopped.
So I've got all the friends as speakers today.
So it's a coincidence, sir.
No. That was done purposely. So happy to be in this position today.
Hi Manish. Hi Rahul.
How are you?
All good. Yeah.
Rishikesh?
Hi Rishikesh. How are you?
Rishikesh, what happened to you? Every 6 months, he changes his look completely.
Inspired by the cricketers, I think.
Hi all, sir. Good evening and nice to meet you all. I am from Glenmark side representing, and I will just do the introduction session and followed by I'll hand over the session to Dr. Manish sir. He will take over it and moderate for today's meeting. So we have a 20 minutes presentation, 15 minutes for presentation, 5 minutes for discussion. So he has instructed that we can keep the Q&A at the end of the. So it is kept at the end of the session after everyone's talk. So that's the flow of the meeting.
Tech team, please let us know when we are going live, please.
We have 2 more minutes to go live.
Perfect.
Tech team, kindly let me know once we are live so that I'll start.
Yeah, so can we go live? Hello.
Yes.
Dr. Navya,
Okay, just
yeah,
a
can
second.
we go live?
Dr. Manish sir, with your permission, can we start?
Oh, definitely.
Yeah. Tech team, please, we can go ahead.
Yes, we are live. We can start.
So, hi, good evening, dear doctors and all the audience who are attending today's session. So, myself, Dr. Navya Cantony from Glenmark Medical Team. Happy to have all of you for today's advanced training program in collaboration with the API session. So, as we all know that Glenmark is renowned for its commitment towards scientific excellence. So, this workshop is an innovative and a comprehensive program mainly designed to elevate your skills and knowledge of the healthcare professionals in echocardiography. So we have leading experts today for the discussion where we will get to know all the detailings of the valvular heart disease, which is part 2. So this is the fourth webinar series in echo, and as we all know how crucial is the echocardiography in day-to-day practice, and it helps us to understand the visualizing the valve structures and all other valve functions and many more. So today's scientific agenda consists of that is the opening session from our moderator, Dr. Manish Bansal sir, followed by we have 4 talks that is on dobutamine stress echocardiography, which is delivered by Dr. Rishikesh sir, and evaluation of prosthetic valve by Dr. Devika ma'am, and then evaluation of tricuspid valve disease by Dr. Vinay Agrawal sir, and echo for transcatheter valvular intervention by Dr. Rahul Mehrotra sir. So with this clinical section, we do have a Q&A session also at the end of the discussion. And also I will post a 3 minutes poll to the audience for understanding your opinions and practice in real case scenarios. So with this, I would like to welcome our course coordinator, Dr. Manish Bansal sir, for today's meeting. He's a Senior Director of Clinical and Preventive Cardiology of Medanta, the Medicity, Gurugaon, and he's also the former Editor-in-Chief and Journal of Indian Academy of Echography as well as Indian Heart Journal, and also former editorial board member of Jack Imagining and Cardiovascular Ultrasound. And he's a recipient of numerous awards and honors and accolades, including gold medal in various subjects like pathology, pediatrics, and cardiology. And he's very much interested in academics and research. Happy to have you on board, sir.
Thank you.
Also, I would like to welcome our first speaker, Dr. Rishikesh Shah. He is a consultant non-invasive cardiologist who is working in Thane Jupiter Hospital, Mumbai, Maharashtra. He is also a member of past Joint Secretary of Indian Academy of Echocardiography, as well as Executive Committee member and Indian Academy of Echocardiography, and also has various research papers in national and international journals, and also keen interested in academics. Happy to have you on board, sir. Our next speaker is Dr. Debika Ma'am Chatterjee. She is a senior consultant and head of department of non-invasive cardiology, Narayana Health, Kolkata. She is having over 25 years of dedicated experience in Kolkata in the field of non-invasive cardiology, and she is recognized as the pioneer in advancing non-invasive cardiac imaging and as well as patient-centered cardiology practices, and faculty at several conferences and academic meetings. And also she is a course director and a resourceful person for workshops and multiple CMEs, which is mainly related to non-invasive cardiology. Happy pleasure to have you on board, ma'am. Also, I would like to welcome Dr. Vinayak Agarwal sir, who is a senior director and head of the clinical cardiology and advanced cardiac imaging, Fortis Memorial Research Institute, Gurugram. He's also having fellowship in multiple organizations like American Heart Failure Association, Society of Echocardiography, and American College of Cardiology. And he's also having various affiliation to various committee members like Cardiology Society of India, and also Indian Academy of Echocardiography is executive committee member and member of editorial advisory board for Indian Heart Journal, cardiovascular case reports especially. And he's also co-investigator for multiple trials like phase 3 trials and some of the important trials like solid TIMI 52 and many more. Happy to have you, sir. We also have our fourth speaker, who is the Dr. Rahul Mehrotra. He is a chief professor of non-invasive cardiology and clinical cardiology at Artemis Hospital, Gurugram, Haryana. He is also the Honorable General Secretary of Indian Academy of Echocardiography in the year 2020 to 24, and treasurer in Indian Academy of Echocardiography in 16 to 20. And also, he is also a member of multiple Delhi NCR chapter for Indian Academy of Echocardiography, and also he has various accolades, especially Dr. M. Chenna Reddy Award and Gold Medal in Cardiology, which is given by the Vice President of India for the best research paper. So honored to have all the esteemed faculties for today's discussion, and we are looking forward to learn more from you, all of you. Thank you. And now I hand over the session to Dr. Manish Bansal sir for taking forward the meeting head.
Yeah. Thank you so much, and good evening, everyone. First of all, I thank Glenmark for creating this excellent platform for sharing echocardiography related knowledge with so many physicians and young cardiologists who are in practice. So as we know, this is the fourth session out of a series of 6 sessions on echo. In the last session, we discussed common valvular lesions like mitral stenosis, mitral regurgitation, aortic stenosis, and aortic regurgitation. In today's session, which is again on valvular heart disease, we are going to discuss more advanced topics and some less discussed or less understood topics related to valvular heart disease, like low gradient aortic stenosis, prosthetic heart valves, tricuspid valve, and role of echo in structural heart interventions. And I'm very pleased to say that we've got 4 excellent speakers to cover these topics. So without wasting any further time, I request first speaker, Dr. Rishikesh Shah, who is going to discuss the role of dobutamine echo in the assessment of low gradient severe AS. Just one request from my side to all my co-faculty members that please restrict the presentation to 15 minutes so that we can have sufficient time for discussion towards the end. So with this, I invite Dr. Rishikesh Shah.
Are you able to hear me?
Yes, yes.
Yes, sir.
You can see your slides also.
Okay, fine. Okay, good evening, everybody. So today my topic of discussion is dobutamine stress echo in low flow, low gradient aortic stenosis. So let's start. So what is basically defined as severe aortic stenosis as per AAC and European criteria? There are four main criteria which are there, in which aortic jet velocity, uh, aortic jet velocity, oh, sorry. Yeah, aortic jet velocity is more than 4 meters per second, while mean gradient is more than 40 millimeters of mercury, as per American Heart Association, like AAC criteria, while the European says it should be more than 50 of Hg. Aortic wall area has to be less than 1 square centimeters. Index aortic wall area, that is aortic wall area index to body surface area of that patient, has to be less than 0.6 centimeters square per meter square, and DVI or velocity ratio of less than 0.25. So these are some 4 to 5 essential criteria. Now we have no problems in diagnosing aortic stenosis if these criteria are concordant. That means if most of these are present or all of these are present. The problem comes when they are discordant, especially when you have a mean grade, when you have an aortic wall area which is less than 0.1, which is less than 1, and mean gradient of less than 40 of Hg. So how do we calculate the aortic wall area? So basically the aortic wall area is calculated by the standard continuity equation, in which you calculate the stroke volume dividing with aortic wall VTI, which you take by CW Doppler across the aortic wall. And stroke volume you calculate by LVOT diameter, which you take in parasternal long axis view, take radius from the diameter, and pi r square into LVOT VTI will give you essentially a stroke volume divided by aortic wall VTI will give you aortic wall area. There is one more formula known as Gorley's formula to calculate aortic wall area, especially in low flow, low gradient stenosis. What does that formula say? That formula says that the aortic wall area can be calculated by flow rate divided by velocity. So what is the flow rate? Flow rate is nothing but stroke volume into systolic ejection period. And stroke volume is what? Cardiac output divided by heart rate. So basically flow rate is stroke volume into systolic ejection period, and velocity is nothing but 44.3 into square root of mean gradient. So this is the modified Gorley's formula, in which we say that cardiac output is nothing divided by 44.3 into heart rate into systolic ejection period with square root of mean gradient. So the discharge coefficient or constants for the calculation have not been precisely defined, and the failing ventricle, why this formula is used, especially in low flow, is the failing ventricle generates inadequate wall opening forces. So let's go further and define, how do you define as low flow, low gradient severe AS? So the basic criteria for that is aortic wall area less than 1 square centimeter or 0.6 square centimeters per meter square, where aortic wall gradient, which normally in classic normal AS you would get more than 40, in this case you get less than 40 millimeters of mercury. Stroke volume index, that stroke volume divided by body surface areas, is 35 ml per meter square or less than 35 ml per meter square, and transvalvular flow rate of less than 250 ml per second. Now these are the 4 criteria in which you define as low flow, low gradient severe aortic stenosis. Now we already know how do you calculate stroke volume, how do you calculate aortic wall area, and how do you calculate stroke volume index. But then the question comes, how do you calculate trans aortic flow rate? So to calculate trans-aortic flow rate, first you need to calculate stroke volume. And stroke volume is calculated by standard formula, which I have already told you, pi r square into LVOT VTI. So you take this diameter, you calculate the radius, and you multiply it by LVOT VTI, you will get the stroke volume. And then what is transvalvular flow rate? Transvalvular flow rate is nothing but what you need to do is stroke volume divided by systolic ejection period. And how do you calculate the systolic ejection period? Is to take CW Doppler across the aortic wall and to measure the ejection time. So from the start to the end of this is known as ejection time, and you divide this stroke volume with this ejection time, you get the transvagal flow rate. The normal transvagal flow rate is 250 ml or more than that. Anything less than 250 ml is termed as low flow. So now, depending upon this low flow gradient, we have further divided this low flow gradient into two parts. One is low EF low flow gradient and normal EF low flow gradient. So low flow is divided into low EF and normal EF. Now low EF can also have either with true AS, or it can have pseudo AS. And true AS can have with contractile reserve or without contractile reserve. So today, while the normal EF low flow low gradient AS is also known as paradoxical low flow low gradient with normal EF, and it is divided further into true AS and pseudo AS. So the basic premise of using dobutamine is into this low EF, low flow, low gradient aortic stenosis, and how dobutamine helps us to ascertain this, that will go further. So these are the three aortic stenosis, the subtypes which we are going to look into. One is the normal flow, which is high gradient. One is the low flow, low gradient with normal EF, which we are not going to look. Even this we are not going to. We are going to concentrate on this low EF patients with low flow, low gradient aortic stenosis. So what is the purpose of dopamine stress echo? The purpose of dopamine stress echo is to differentiate between whether there is presence of true aortic stenosis or pseudo aortic stenosis. That means if there is aortic stenosis or not in the first place, and to look for presence or absence of contractile reserve. So these are the two main purposes of doing a dobutamine stress echo in low EF, low flow gradient stenosis. So what we do basically in that is we start with a baseline echo, and then we look and we take transvagal flow rate, aortic wall area, stroke volume, mean gradient in all these patients. And then we slowly increase the dobutamine every 5 minutes, starting from 5 mics to 10, 7.5 times, 15, and 20. We never exceed dobutamine stress echo, low dose, low gradient dobutamine stress echo, more than 20 micrograms per kilogram per minute. So how do we differentiate on basis of dopamine? So what are the criteria of dopamine? So most important thing is, first is how to differentiate between true and pseudo AS. In people with true AS, the aortic wall area essentially remains unchanged or even reduced. So the aortic wall area throughout the dobutamine will always be less than 1. While in pseudo AS, the aortic wall area, as the flow increases, will increase more than 1, 1.2 or something like that. Secondly, how will you know whether this patient has contractile reserve or not? So the contractile reserve will, again, if the patient's stroke volume has increased more than 20% from the baseline, we'll say that this patient has a contractile reserve. And if the patient do not increase the stroke volume by more than 20% on dobutamine, then we say this patient does not have contractile reserve. So these are the main two essential criteria in dobutamine. Now about the projected aortic wall area, we'll come ahead as we discuss the cases. I'll go through and I'll explain to you in detail. What about the mean gradient? Mean gradient in dobutamine stress echo in true AS will be 40 or in more than 40. But in pseudo AS, as will grow more and more, it may not increase it may not increase at all, or rather it may reduce. So when in true AS, the mean gradient will always cross more than 40 mm of H in dobutamine. So let's go and study about the dobutamine. So let's go into the cases. So this is an 81 years old male with past history of LVF, history of PCI with BP of 170 by 80, while body surface area of 1.78. And this is his echo. You can see the posterior wall is essentially akinetic, while there is generalized LV hypokinesia. The LV is depressed, definitely, and the aortic wall is heavily calcified and it's not opening. So this is a zoomed out view of the aortic wall, the same showing it's quite calcific with very restricted opening. And color interrogation shows us that there is definitely obstruction there. And there is some amount of AR, which is hardly grade 1 or something. And there's some amount of MR also. And this is the short axis view, which confirms that infraposterior wall is kinetic, while all other walls are quite hypokinetic comparatively. Yeah. And this is the 4-chamber and 2-chamber view. You can see that. Definitely this patient's EF is low. And then the aortic wall is calcified. We already saw that. And there is AR and MR. Okay. So this is his interrogation, this thing. Oh, just a minute. There's something which is coming up here. Oh. Okay. So the patient's mean gradient, I cannot see those gradients here on my screen too. Okay. Sorry, there's some problem there. Okay. Okay. So anyway, I'm unable to see this. This live meeting is live stream is coming there. How can I close that? Can somebody guide me, please, from the technical team?
Technical team, can you just help Dr. Rishikesh sir
Yeah,
on here?
doctor.
See this, I am getting this strip which is closing my this thing screen. This meeting is being live stripped. How do I remove that?
Click on that YouTube option, then you can minimize that.
Sorry?
Click on that YouTube option twice.
YouTube option. Okay.
Yeah, at the top you see the YouTube. YouTube is there. Just click on that.
I can't see that. Okay. No. I am unable to see.
I think you can unshare and share again, Rishikesh.
Okay. No, this okay, okay. Okay, can you unshare me, please? I'll unshare it again. Okay, I'll share that again. I have to remove this option first. Okay, okay, fine. Okay. Right, can you see my screen now?
Yes, sir.
Okay, okay. Just a minute. Now let me just comment also. Okay. Okay. Yeah. So the patient's resting gradients were 43 by 27 mm of Hg, while stroke volume index was 28 ml per meter square. So definitely fitting into our criteria of low flow. Aortic wall area was 0.73 centimeters square. So that's again a very severe AS, which we got as per the criteria for low flow. And transvalvular flow rate, which has to be around 250 ml. In this patient, it came out to be resting transvalvular flow rate was around 186 ml per second. So we did his dobutamine, and these were his 5 mics. This thing at every stage of dobutamine, we took a stroke volume, we took aortic wall VTI, we took LVOT VTI, and we took the ejection time. Then again, we went to 10, 15, and these are the readings. Now let's understand these readings one by one. So you can see first concentrate on SV, which is the stroke volume. Yeah. So first concentrate on stroke volume. You can see the resting stroke volume of this patient was 51, and at the peak dobutamine, it went to 65. So this patient definitely has increase of the stroke volume by 15 ml, so which is more than 20% of this. So this one thing is for sure, with dobutamine, this patient has increased his stroke volume. So this patient definitely has cardiac rhythm. Now let's go to the aortic wall area. Now the aortic wall area, the resting what we got was 0.73 square centimeters, while at the peak we got was 0.82 square centimeters. Now at 0.82 centimeters, we have to check what was the flow rate. at 0.82, the flow rate was 252. So we started at 186 and we managed to increase the flow rate by 252. So at 252, aortic wall area still couldn't cross 0.82. So this was nothing but this patient definitely has true severe aortic stenosis with good contractile reserve. So here, dobutamine helped us to find it out whether it was true or pseudo. So it was definitely true, or whether this patient has contractile reserve or not. So this patient definitely had a contractile reserve. Now let's go to the next case. This was a patient with a body surface area of 171.7 square meters, LVOT diameter of 22 and BP of 110. And this is it, generalized LV hypokinesia. You can see this. Here also his aortic wall is heavily calcified. It shows very restricted opening, not opening well. Again, the aortic wall is, you can see this zoomed view. And this was it. There's hardly any AR there, trivial AR. And this is at peak exercise. You can see the LV, which was hardly contracting, now has become hyperdynamic at the peak dobutamine. So this was his resting gradients. Peak by mean was 42 by 24. So 24 is less than 40. So definitely these gradients were less. While his aortic wall area was 0.78, which was definitely less than 1. So it was definitely severe AS, which we got. Stroke volume index was less than 35 ml per meter. So it was 29. And transvalular flow rate was very, very low. It was 166 ml per second. So this patient fits into typical low flow, low gradient, low EF aortic stenosis. Now let's go ahead and look at his dobutamine. So again, we did the same thing. We calculated the LVOT VTI, aortic wall VTI, ejection time at each and every stages of 5, 10, 15, 20 miles. And now these are its readings. So let us understand these readings again. In this patient, again, let's start with stroke volume. The stroke volume at rest was 50 ml, while at peak exercise was 69 or almost 70 ml. So this patient managed to increase his stroke volume by more than 20%. So that's for sure this patient has excellent stroke volume, and which we could also see at peak exercise of dobutamine images, how hyperdynamic that LV had become. Now let us go to the aortic wall area. The aortic wall area at rest is 0.78 square centimeters, but at peak exercise, it became to 1.2 square centimeters. So this aortic wall area had jumped from 0.78 to 1.1. So definitely this is not severe AS. Now to validate if this aortic wall area which we got was about 250 ml, we'll go back and look at transvalvular flow rate. And the transvalvular flow rate at that particular point of time, when we got aortic wall area of 1.2, was 345 ml per second. So at high transvalvular flow rate, this aortic wall opened. So what we got was actually pseudo-severe aortic stenosis. So this patient has aortic stenosis, but it is definitely not severe. But one thing is for sure, this patient has got good cardiac reserve. So we can follow up with medical management, and later whenever this aortic wall becomes severe, we can go and intervene it. Let's come to the third case. This patient is having generalized LV hypokinesia. Basically, he has LVBB dilated cardiomyopathy, which you can see. He has got dysynchronous septal motion, which is quite consistent with LVBB. Again, in short axis view, you can see there is quite amount of LVBB here. And this is his short axis view of aortic wall. Aortic wall, we can see, which is heavily calcified and not opening well. So here you can see this aortic wall zoomed view again. So again, his resting gradients were 52. Aortic wall area was around 0.58 meter square, so less than 1. Stroke volume index was around 30 ml per meter square, so less than 35 ml per meter square. And transvalvular flow rate was just 156 ml per second, so way below our 25 ml, 250 ml per second cutoff. So this patient again is a type of low flow, low EF aortic stenosis. So again, we went back, did a dobutamine, did all the parameters, looked into it, went to 5, 10, 15, 20, and this is what we got. Okay, so now let us see what is happening in this patient. So here you saw his resting stroke volume was 52, but at peak exercise, instead of increasing, the stroke volume rather reduced. Okay, So this patient definitely does not have any cardiac reserve. No cardiac reserve was there in this patient. Now, what about the aortic wall area? The aortic wall area at rest was 0.58 square centimeters, but at peak was 0.64. But then question is, should we validate this 0.64? At what transvalvular flow rate did we get this 0.64? We got this 0.64 at transvalvular rate of 184. Now here is the problem. We couldn't achieve the transvalvular flow rate of 250 ml per second on dobutamine. The resting was 156. We managed to increase the transvalvular flow rate to 184, but we couldn't go to 250 ml. So how do we interpret this dobutamine now? The stroke volume did not increase. The aortic wall area is still quite less than 1. And transvalvular flow rate did increase, but did not cross this 250 ml. Now, in this cases, the concept of projected aortic wall area. So what you do is you plot all the aortic wall areas which you get at different flow rates. You draw a line, and then whatever aortic wall area you get at 250 ml per second, you take that aortic wall area as the aortic wall area which the patient would have if we would have proceeded to achieve dobutamine stress required at 250 ml per second. So the formula to calculate it, EOA projected is EOA at rest. So whatever rest aortic wall area we got that, plus we got what is known as wall compliance. Now what is wall compliance? Wall compliance is nothing but difference in EOA divided by difference in flow rate. So what you do is you take the EOA at peak, subtract it by EOA at baseline, divided by flow rate at peak, divided by subtract it from flow rate at baseline, and we will this division of this 0.5247, you will get this wall compliance, which is 0.0021 in this case, and then you add this EOA to wall compliance and multiplied it by 250 ml. This is what we wanted wall area at, minus whatever was the transvalvular flow rate at rest. So in this patient, the EOA EOA rest was 0.7. The wall compliance was 0.0021 multiplied by 250 minus 130. It came out to be 0.97. So this patient definitely had severe aortic stenosis, which was less than 0.1 with no contractile reserve. So in patients in whom you couldn't achieve the contractile reserve, you need to use this formula and derive the contracted reserve at 250 ml per second, or it is also known as projected aortic wall area at a flow rate of 250 ml per second. Now, how do you define the contractile reserve basically? So as I said earlier, if the stroke volume increases by 20% of its baseline on incremental doses of dobutamine, then we call it presence of contractile reserve. So why do we don't get any contractile reserve even after giving dobutamine? Because there is afterload mismatch, there is inadequate increase of myocardial blood flow due to associated coronary artery disease, or there is irreversible myocardial damage in form of MI or myocardial fibrosis, which do not increase the contractile reserve of the patient's heart. So has it gone to bearing on the prognosis? Yes. So if you get no contractile reserve on DAC, the perioperative mortality is as high as 32%. So that is a surgical area. While survivors have significant comparable improvements in LVF and New York Heart Association class, they have a very, very high mortality on medical management. And this was by Monin. So this is a paper which tells us, which compares us surgical AVR in group A patients, that is with contractile reserve, and in group 2 patients without contractile reserve. You can clearly see. Yes.
We'll have to come to the last slide.
Yes, sir. 1 minute. So you can see the group A patients have a good, prognosis compared to group 2 patients who do not have contractile reserve. But in TOWER, the contractile reserve doesn't matter. As you can see, both the patients develop shows good response. So in TOWER, looking for contractile reserve on dobutamine does not matter, but it matters to differentiate between severe AS and 2A. So this is just a last slide which tells us the algorithm which gives us how we go about. So if the stroke volume increases by 20%, mean gradient increases by 40 mm of Hg and EOA is less than 1, this is true severe AS. And depending upon the risk, you can either go for tower or sour. Then in patients with who have increase of 20%, while mean gradient remains below 40, while EOA is more than 1, this patient has pseudo-severe AS, you can wait, continue the medical management. While those patients who do not decrease 20% and no contracted reserve, this patients, it is preferable to undergo tower. So this is all. Thank you for your patience. You can unshare.
Thank you so much, Rishikesh, for a very exhaustive coverage of low gradient AS, the role of vitamin echo, and you showed some very nice examples also to explain the concepts behind this whole issue. And so we'll come to the questions towards the end. We will now move to the next presentation, and for that I request Dr. Devika Chatterjee. She will be talking about prosthetic heart valves, another very complex topic.
Yeah.
But we are going to discuss the key concepts so that it becomes easy for all the practitioners out there.
Yeah, thank you, Manish. And so let me start. As we know, the valvular heart disease is a major health problem worldwide, and the prosthetic valve implantation has dramatically changed the outcome of the valvular heart disease. So we have to know how to assess the prosthetic valve. We always use a very consistent and a methodological approach for the evaluation to get all the information about its function, and also we identify any change in the valve function, and also we detect any complication. We have to know the type and design of the prosthesis because it plays a great role. The fluid dynamics varies from prosthesis to prosthesis. So basically there are two types. One is the mechanical prosthesis, where there is a single leaflet or a double leaflet, double disc, as you can see, and a ball and cage. So here leaflets, the discs are the occluder, and in the ball and cage, it is the ball, which is the occluder, but it is not available right now because of the robust size. It has been outdated. Another variety is the tissue prosthesis valve, where the leaflets are made from porcine, aortic valve, or bovine pericardium, where it has 3 struts and 3 leaflets. As you can see here, 3 struts. Now, the echocardiography follow-up in a prosthetic valve patient is very, very important. We must have the baseline post-operative echo report in hand every time. And then 2 to 4 weeks after the hospital discharge, another echo, and then routine echo annually with earlier echo if there is any change in the clinical status. We must have certain essential information before we start doing echo in a prosthetic valve. What is the indication of the valve? From the indication, we get a clue, like what type of problem we are facing. If there is fever, we'll look for the vegetation. If there is a history of stroke, we'll look for a thrombus, and new murmur indicates adhesions and paravalvular leak, etc. We should know what was the indication of the valve replacement, date of surgery, type and size of the prosthesis, because the hemodynamics vary, according to the type and size of the prosthesis. INR, latest INR, the coagulation profile we have to know. Also, we have to know height, weight, and body surface area of the patient to assess the patient prosthetic mismatch. And of course, it is the heart rate and BP. These two have great role in the, the gradient across the prosthetic valve. The transthoracic echo is most useful, most friendly. We look at the opening of the leaflets, so the occluder. We look at the stability of the prosthesis, presence of any thrombus, thrombus or vegetation, etc. We also, along with these, assess the chamber size, ventricular systolic function, diastolic function, and of course the thickness. But we always face certain special problems in imaging of the prosthesis. Often we get frustrating image because of the acoustic shadowing and the reverberation behind the prosthesis. We can't see the LA in a case of mitral prosthesis in transthoracic echo. The moment we switch over to the transesophageal, you see, we can see the prosthesis, and I mean, the posterior aspect now becomes anterior. LA is now proximal in T. It was distal in transthoracic, so the LA is clear now. So that way, TE complements the transthoracic echo. We also face certain we come across with the physiological processes like microbubbles. These are the normal findings. These are not any, they do not reflect, they don't look like vegetation or thrombus often. They are not thrombus or vegetation. They are quite normal findings. These are bright, highly mobile, small, loose echogenic particles occur due to the microcavitation by the impact of the occluder against the swing ring. And the spontaneous echo contrast, as is seen in the ALA in case of mitral prosthesis, is quite normal because we know all the prosthetic valves are inherently stenotic. Now, blood flow across the prosthetic valve differs greatly from a native valve. It depends on the valve type, size, etc. So we have to know how is the blood flow pattern in a specific prosthesis. And as I said, all prosthetic valves are inherently stenotic. But we always evaluate for stenosis if we get a mean gradient across the aortic valve more than 20, or in mitral more than, say, 10 millimeter of mercury, that is the mean gradient. Now we also look at the effective orifice area other than the gradient, which we get by dividing the stroke volume by VTI of that particular prosthesis. We look for the stenosis suggestive. We suggest stenosis if the effective orifice area is less than 0.8 square centimeter in case of aortic, or if it is less than 1 square centimeter in case of mitral. Now, as we know, mild transvalvular regurgitation is quite common. These are called wash jets. These are caused by a motion of the disc. They reduce the risk of thrombus. In case of bileaflet prosthesis, there are two, and I mean three jets, because three orifices in bileaflet and two jets in a monoleaflet. But you may say, where are the regurgitation in this case? Well, those are there, but these are hidden by the acoustic shadowing. The moment you switch over to the transesophageal, as you can see, you can't see here, but here you can see clearly the three transvalvular regurgitation jets. So, and that way T complements the transthoracic echo. Now, when you get a transvalvular regurgitation, it is quite normal. We always look at the degree of transvalvular. If it is quite significant, it is to be evaluated further. Now, a bileaflet prosthetic valve looks like this. You can see the two dots in the LV. It's normally moving with three orifices and the mean gradient of 3. Always avoid the central jet while measuring the pressure gradient because it gives a very high gradient. We avoid it. Monoleaflet looks like this, and a mean gradient of 2 here. And in transesophageal, you can see clearly there are two orifices. Flow takes place through two orifices. Ball and cage has a very unique flow pattern. As you can see, the ball is moving up and down. The cage is in the LV, and there are flows on the either side of the cage with a mean gradient of 4. So that way we see, and this is the aortic prosthesis bileaflet with a mean gradient of 17. And now let us go see the tissue prosthetic valve. See here, these are the biological tissue prosthesis and a mean gradient of 3 millimeter of mercury, quite normal. Now, till now, we have seen the normal function, but we must not forget that all the prosthetic valves are very, very notorious. by virtue of their design and the function, they are prone to develop certain dysfunctions from time to time. The incidence is 2 to 3 out of 100 patients with prosthetic heart valve per year, not in their whole life, it is per year, so it's quite high. Keeping these statistics in the back of your mind, you must recommend for prosthetic valve implantation. Sometimes these complications are so severe that they need immediate urgent intervention. So at times you will have a feeling that you are trading the native valvular heart disease with prosthetic heart valve disease. So these complications are needed to be diagnosed very early, very crucial it is, and clinical examination is often not reliable. It is the echocardiography which plays a great role. We need to use multiple views, off-axis views, and transesophageal echo is mandatory if we suspect any dysfunction. Now, a dysfunction depends on the type of the prosthesis, whether it's mechanical or biological. In mechanical, the obstruction is more due to thrombus, pannus, or vegetation. On the contrary, in the biological valve, it is due to the degeneration for which the valve gets the obstruction. And mechanical failure occurs in mechanical prosthesis and structural failure in biological prosthesis. So now let us see a complication like paravalvular leak. It is due to the inappropriate sealing of the prosthesis. As you can see, this is the mitral prosthesis. And sealing of the sewing ring to the native annulus. Now, if it occurs early, it is due to suture technique. Some surgeons prefer the continuous suture instead of interrupted. Those cases usually are prone to develop paravalvular leak. But if it occurs late, it is due to either endocarditis or suture dehiscence. So now, in this case, you see there is a paravalvular leak. And as soon as we get this type of finding, we go for transesophageal echo, and I can see there is a gap here through which the severe mitral regurgitation is taking place. And I measure the size as it is in two-dimensional echo. This is not the true size because transvalvular leak often they are crescent shaped, and that can be picked up only by transesophageal echo. Look, here this is a sewing ring in transesophageal three-dimensional echo. We can pick up the shape of the paravalvular leak. It is crescent shaped, not a cylindrical as we got in two-dimensional transesophageal. And by providing on-fast view of the mitral prosthesis, we can localize, and the interventionist can go with the device to close it with no residual regurgitation. Now, elevated gradient is another problem, which might be due to the intrinsic valve dysfunction by thrombus, pannus, vegetation, or calcific degeneration in biological valve, or patient prosthetic mismatch. But sometimes we must remember there might not be some intrinsic cause at all. It might be only due to the hyperdynamic flow of the patient, or presence of regurgitation increases the gradient, or if by error we measure the central jet artifact, which I have already explained. Now, so our approach to a high gradient in a patient, we always should measure the Doppler velocity index by dividing the VTI of LVOT with the VTI of the prosthetic valve. If it is normal, it is not due to intrinsic problem. It is due to high flow state or localized high gradient in the central orifice or some technical error. But if we get abnormal DVI, an abnormal DVI indicates intrinsic valve dysfunction or patient prosthetic mismatch. Now, once we get elevated gradient, we must have the four information in our hand. One is the baseline echo study to compare the gradient, the latest INR, which reflect the coagulation profile of the patient, time of onset of the symptoms like shortness of breath, and also the age of the prosthesis, because depending on these 4 or 5 parameters, we are going to differentiate by echocardiography whether the obstruction is due to panels or thrombus. Here is a patient who had a M here with bileaflet 2 years back, complaining of sudden onset SOB. INR is low, irregular anticoagulation, and baseline echo showed a normal prosthesis with a normal gradient. But what is happening now? We are getting a gradient, mean gradient of 24 millimeter of mercury across the mitral bileaflet prosthesis. So we go for transesophageal echo. And what we find, one disc is not moving at all, the other disc is moving. And also in the three-dimensional transesophageal echo, you can see one orifice is seen. The central and the another bigger orifice is not opening at all, and we are getting a mean gradient of 23 millimeter of mercury. So if we now look, what is the problem? INR is low, it is sudden in onset, it is of shorter duration, the age of the prosthesis is short, and there is a sudden increase of pressure gradient. So all are in favor of thrombus. So we do the thrombolysis. It's a miracle. It opens up the stuck valve, and we are getting now gradient of 3 millimeter of mercury. Look at the three-dimensional transesophageal echo. You can see all the 3 orifices now clearly. Now, another patient who had a mitral prosthetic valve implantation 12 years back is having slow onset shortness of breath, regular anticoagulation with INR of 3. Baseline echo was normal, but his serial echoes are showing gradually increasing pressure gradient. This is a transesophageal echo, and we get a very, very high gradient, mean gradient of 19 across the mitral prosthesis. So what it is? The PANAS can be diagnosed with the help of three-dimensional transesophageal echo. See here, see around the swing ring, there is overgrowth of the tissue, which is called the PANAS, fibrous tissue, and it is also proceeding towards the hinge, and so that is why there is a high gradient. In this type of case, there is no role of thrombolytic therapy. You have to redo the surgery. So now if we see INR in this patient, INR is normal, slow onset symptom. Duration is longer. It is not sudden in onset. And age of the prosthesis is very large. I mean, around 12, 13 years back, the implantation was done and gradually increasing pressure gradient. So it has to be PANOS. Now another patient, this is the third patient. 1 year back, patient had the implantation, SOB, latest INR is good, 3, but the baseline echo was showing very high gradient across the prosthesis. So here is the aortic prosthesis. There is a trivial transvalvular aortic regurgitation. And as we see the gradient from the apical 5 chamber, we get a mean gradient of 52 millimeter of mercury, which is very high, indicating severe stenosis. We go to the transesophageal, and in the transgastric view, you see the 2 discs are moving normally in an inverted V shape. Can you appreciate it? In transthoracic, often we can't see the discs properly, but here we can see it clearly. So we do the fluoroscopy. See here, both the discs are opening nicely, see? So what it is basically the size of the prosthesis is small for the body surface area, resulting in a condition called patient prosthetic mismatch. That results in functional stenosis with a very high gradient, though there is no thrombus, panus, or vegetation, and the leaflet motion is absolutely normal. So we do indexed effective orifice area in these cases. Manufacturers provide the chart of the projected indexed effective orifice area. We can always compare according to the patient's body surface area and the prosthetic size. So the last patient with high gradient is a tissue prosthetic valve. Patient had the implantation 10 years back. Dyspnea, baseline echo showed normal gradient, but serial echo for last 2 to 3 years showing gradually increasing pressure gradient. So what we get, look at the tissue prosthesis in the mitral position. A lot of calcium is there. And there is a mean gradient of 23 millimeter of mercury across mitral prosthesis, which is very high. Actually, see, if you look here, this should be the normal motion of the tissue prosthesis. You see the two leaflets are moving normally, but in this particular patient, hardly there is any opening of the prosthesis, and that is due to the structural deterioration in the tissue prosthesis, which is a spontaneous degenerative process leading to the thickening, calcification, reduced mobility, and ultimately obstruction and elevated gradient. So, and last of all, it is the complication, I mean, is the prosthetic valve endocarditis. It is our nightmare, both for the doctors and the patient. Now, the certain facts about the infective endocarditis is that it has cumulative risk within 5 years is 3 to 6%. Both the biological and mechanical prosthesis can be affected, and it is difficult to detect by transthoracic echo. The findings of infective endocarditis, always it needs transesophageal echo. The various echo findings which we get in endocarditis are vegetation, dehiscence leading to paravalvular leak, even abscess and fistula. And it can cause both regurgitation and obstruction. A large vegetation can give rise to a very high gradient. Here is a patient who had an MVR 1 month back, complaining of fever for 10 days with a WBC count of 14,000, high, CRP 40. Now in transthoracic, we suspected a small mass, and we say, look at the transesophageal liquid, it's clearly seen. So sensitivity of and specificity of transesophageal echo is very high in picking up the vegetations in case of prosthetic valve endocarditis. Often we can't see because the transthoracic echo, a lot of shadowing, acoustic shadowing, reverberation artifacts are there. So we always do the transesophageal echo. And this type of dehiscence also may occur. You see the mitral prosthesis is showing rocking motion, and there is a gap. This is aorta, a transesophageal echo, and through that severe regurgitation is taking place. It is a life-threatening, devastating complication of infective endocarditis in a prosthetic valve. Only surgical intervention can save this type of patients. So at the end, my message is that though the prosthetic valve evaluation is challenging, and but if we are very careful, we go forward with a systematic approach, and we have a high index of suspicion of various types of complication, then we can detect all the complications and we can reduce the morbidity and mortality. Thank you.
Yeah, thank you, Dr. Devika, for excellent presentation. You showed so many nice examples. And I think the message that you gave is very important, that in case of prosthetic heart valve disease, rather than getting intimidated, if one just looks at the whole thing in a systematic manner, then most often it will be possible to get to the correct answer and diagnosis. So as discussed, we'll take the questions towards the end. And I now invite Dr. Vinayak Agrawal to speak on tricuspid valve disease, which is another very, very important topic. And its importance we are now realizing increasingly. So very important topic. And Dr. Vinayak Agrawal.
Thank you, Dr. Manish, and thank you for the opportunity. Okay, so I will be talking about tricuspid valve in short, about 15 to 20 minutes, and try to touch upon the most important aspects of this not so forgotten valve now. At one time, we used to talk about it as a forgotten valve, but it is not so now. So tricuspid valve is the largest and most apically positioned valve And just like mitral valve, it has 4 components, including the annulus, which is quite different from mitral valve because it doesn't have a fibrous structure. It is actually attached to the RV and RA and doesn't have such a robust, say, skeleton as a mitral valve has. It also has 3 leaflets, but then we will discuss that as well. Papillary muscles and caudal attachments, just like you have in mitral valve. So if you look at the anatomy of tricuspid valve, you can see that the valve actually so you have the most anterior valve is the pulmonary valve, then the aortic valve. Just behind the non-coronary cusp, you have the tricuspid valve, which with 3 leaflets as shown, anterior, posterior, and septal leaflets. And this is the triangle of Cox with this purple dot being the AV node. So a lot of important structures like the coronary sinus, AV node, the triangle of Cox, which is very important from the electrophysiology perspective. So you can see that in this triangle of Koch, you have the bundle of His, the atrioventricular node, and you also have very important structures like the aortic root, the NCC, and the right coronary artery actually courses along the anterolateral aspect of the tricuspid valve. The leaflets of tricuspid valve are quite thin and delicate and are less prone to calcification, also because it is a low pressure system. So you can see that in this gross specimen, you have a posterior papillary muscle. This is an opened up right ventricle. So this is the anterior tricuspid leaflet, which you can see is very thin. The papillary muscle attached to it, septal papillary muscle, the septal leaflets, which are mostly adherent to the wall. They may not have a significant papillary muscle or the caudal. They may be have caudal attachment to the wall. And then you have the posterior tricuspid leaflets. Now, when you talk about the topography and what Dr. Manish was saying, why is it becoming very important to know about the tricuspid valve anatomy is because now you have tricuspid valve interventions like TEER, tricuspid TEER, and some of the new valves which are coming like Evoke and all are going to be talked about a lot in the next few years. If you look at this anatomy here, you have an aortic valve in front with the NCC, and then you have these 3 commissures, so red commissure is the anteroseptal one, the blue one is the posteroseptal, and this purple dot is the anterior papillary muscle, and in relation to that, you have the anteroposterior commissure, and then attached 3 leaflets, as you can see here. Important to know the structures, like as I said, the RCA, the coronary sinus, and the aortic valve are in relation. And this is important because when you start to look at, so what changed this perspective about tricuspid valve was the advent of 3D transesophageal echo and also transthoracic echo, because now the imagery is much better as compared to what it was. And what it threw in the last, say, 5-6 years is the completely new nomenclature for tricuspid valve. So now we know that tricuspid valves can be quite deceptive. There is a huge anatomical variation with tricuspid valves. You can have a type 1, which is classical 3 leaflet, ATL, PTL, and septal. You can have type 2, which is just 2 leaflets, which are very large anteroposterior leaflet and a distinct septal leaflet. Type 3 can be divided into 3 types, A, B, and C, depending on if you have 2 anterior leaflets, 2 posterior leaflets, or 2 septal leaflets, then they would be classified as A, B, and C. This type 3B is the commonest actually, which has been shown as the commonest variation that we see in about 30% cases in the JACC article 2021. And then there is a type 4, which is basically 5 leaflets, where you have both the anterior and posterior leaflets divided into 2 each. So this nomenclature is important, and you can see these are some of the types. So this is a type 1 classical 3 leaflet. You have these 4 leaflets, which is 3B, which is the commonest variety that you see. And then you have type 4, where you actually have 2 anterior and 2 posterior. So this is type 4. Now, it is also important, since we will be talking only about transthoracic echo today and not transesophageal echo, we should also know about the 4 views that we look at for the tricuspid valve. The most common is so you put a Plaque's view and then parasternal right ventricular inflow view, which is this one, and you can see ATL and PTL or septal leaflets in this view. Similarly, this 4-chamber view, you can have a septal NAD. Just going to dwell on it a little more. Subcostal views, and then you have the subcostal coronal view, which can look at the tricuspid leaflets. Now, in the parasternal right ventricular inflow view, if you are seeing the right ventricle anterior wall and the septum, so this is LV, RV, and this is the septum here, coronary sinus almost always will be imaged in this inflow, RV inflow view. So the one which is towards the anterior wall is the ATL, or anterior tricuspid leaflet, and the one which is leaflet near the coronary sinus here will be the septal leaflet. This is when you can see the septum, interventricular septum. If you rotate the probe and slightly, inward dipping, you can eliminate the IVS and just look at the inferior wall and the anterior wall of the RV. In that position, the anterior leaflet remains the same, but the septal can be posterior leaflet also. So it can be either posterior or septal leaflet in this view. In the parasternal, so this is what I was trying to explain, that the moment you get rid of the septum and you can only see the RV, then it is either a PTL or a septal. But mostly, if you can eliminate the coronary sinus and the IVS completely, then you're most likely looking at the posterior leaflet. In the 4-chamber, in the parasternal short axis view, it is quite variable, because if you look at, sometimes you just see a single leaflet here, okay, which is always will be an anterior tricuspid leaflet or ATL in a single leaflet. If you rotate it slightly, you start seeing, so this is the aortic valve in on fast view. Then here the RVOT is opened up, and the first leaflet which you see will be septal, and the second which you see on the other side, when you see only 2 leaflets, it can be either anterior or posterior. If you see 3 leaflets in this view, then the one which is attached to the aortic root will be septal, and then anterior and the posterior. So this is some, you will get an idea. The best is, of course, to do a 3D, but on 2D, this is how you identify the tricuspid valve leaflets. Similarly, when you do a 4-chamber view, you mostly see a septal and an anterior. Especially when you angle it anteriorly to visualize the aorta, so you open up the aorta, it is an anterior view, you will see the septum and the aortic valve. If you go posteriorly to open up the CS, coronary sinus, then you're most likely looking at the PTL. Now coming to the second part, which is the annulus, which is very, very important, because it's extremely important in terms of understanding the tricuspid valve pathology. The tricuspid valve, if you look carefully, it is actually angulated vertically. It's almost like a vertical valve between the RA and the RV. So it's actually inclined vertically. And the highest point is the anteroseptal segment, and the lowest point is the posteroseptal segment of the tricuspid valve. So, and this line which you see here is the transverse pericardial sinus. So what is most important to understand is that as the RA-RV dilate, the tricuspid annulus will dilate too. And it is providing the leaflet attachments, and it leads to tethering if the RV dilates a lot, and will also cause similar sort of a change, which I will just show you whenever there is a stretching of the annulus. The leaflet attachment is in the ratio of 1, 1, and 0.75 of the anterior septal, and posterior one has the least radial attachment, circumferential attachment to the tricuspid valve leaflet, annulus. And this is very important, that because there is no fibrous continuity, and the septal leaflet is actually the one which is most, say, stuck to the wall, it doesn't change much. But the anterior and posterior leaflets of the part of the annulus will stretch in an elongated way. And because the septal leaflet is fixed, so that remains fixed, the other anterior and posterior part of the annulus will stretch and lengthen it, making it more elongated. from a saddle shape to an elongated, and that is the reason why you get functional TR. So another important thing to remember is that you need an RV focused view for RV measurements. Analysis is done in RV focused view where you bring the RV into the center of the imaging plane, and if this RV focused view will have slightly larger annular diameter than the normal apical four chamber view, and the measurement has to be done at end diastole. Why this is important is because if you have a diameter more than 40 millimeter or more than 21 millimeter per meter square, then that becomes an indication for intervention. So as I said, that tricuspid valve imaging is challenging, and there are various options that we have. We will be talking only about the transthoracic echo today, but 3DT, 2DT, you have the CMR and CT also, which I'm not going to go into, but they're extremely important. Especially the CT is very important, especially with the interventional modalities coming in. Now coming to the tricuspid valve disease. Tricuspid regurgitation is actually quite common, especially the mild to moderate variety. Severe TR is also common, seen in about 4 to 5% population above 75 years of age. And it is much more common in an aging population. And if you look at the causes of TR, it can be primary, which is organic TR, where there is a problem, genuine problem with the tricuspid valve. So it can be degenerative in annular aging, as in elderly patients. There can be rheumatic heart disease, carcinoid heart disease, endocarditis, congenital heart disease like tricuspid valve dysplasias, damage from the endomyocardial biopsy or trauma, and of course, pacemaker impingement, which is a different entity altogether, but comes under the primary TR kind of a category. Secondary TR can be two types. It can be because of the RV dilatation or right atrial dilatation. So you can have two types of functional TR, can be ventricular or atrial type. For example, left-sided valvular heart disease, which I'll show you an example, pulmonary hypertension, RV infarct, RV MI, RV pacing, etc., can lead to the ventricular TR. The atrial TR is secondary to atrial fibrillation most commonly, or HFpEF. So let's take an example. This was a patient of tricuspid valve vegetation who has the vegetation on the tricuspid valve. Here you can see this is an inflow view. The septum is not seen. So this is attached to the ATL, and this leaflet which you see here will be either a septal or a PTL, most likely a septal one. So similar in this, you can see that the RV is opened up. LV, this is LV and RV, and you can see the interventricular septum here. So here you have ATL, and this will be your septal leaflet. This is another vegetation in a pregnant woman who came to us with severe sepsis, and you can see large vegetations attached to the tricuspid valve with severe TR. This is another case of tricuspid valve prolapse, and there was actually non-coaptation of the tricuspid valve leaflets. You can see that there is no no coaptation of the tricuspid valve with torrential TR. Another case of ARVC, where you can see very large aneurysms at the apex and also at the base of the right ventricular free wall. And this was non-coaptation of the tricuspid valve with severe, again, torrential TR because of non-coaptation. This is another example of a carcinoid heart disease where you can see board-like tricuspid valve leaflets with severe TR. And these patients have very classical board-like tricuspid valve retracted immobile leaflets with both TSTR. And this is typically the mean pressure gradient is 5 millimeter in the presence of severe TR, but you can see this rapid early peaking of the TR jet, which is with rapid decline, dagger shaped, typical of the severe TR. This was the pulmonary valve, which you can see here. There is retracted pulmonary valve leaflets with severe TR, severe PR also, and these patients, there's a typical severe PR in carcinoid heart disease. The secondary TR is, as I said, can be secondary to LV dysfunction, can be pulmonary hypertension, etc. Let's take some of the examples. This is a case of the dilated cardiomyopathy. EF is hardly 20%. And you can see there is significant severe mitral regurgitation and also moderate tricuspid regurgitation with PA pressures. RVSP is about 63. So PA pressures were almost 80 plus. And this is classical of the secondary TR. Another case of severe aortic regurgitation, very eccentric, deceptive AR jet. And here again, you can see a PA pressure, RV pressure of 73 with CVP of 15, severe LV dysfunction causing severe pulmonary hypertension and secondary TR. This is a case of ILD. You can see this patient had a PA pressure of around RVSP of 67 and RA-RV both are dilated in this case of cor pulmonale. This is a case of pulmonary embolism. You can see a large clot in the D-shaped septum. RV is significantly dilated. There is a clot at the RV, some large clot at the saddle, clot at the saddle and pulmonary embolism at the bifurcation of the pulmonary arteries. Both RA-RV are significantly dilated with tethering of the leaflets and severe TR with PA pressures again very high. So this sort of a thing which you see, and one of the things which you see in these chronic pulmonary hypertension patients or patients who have significantly dilated RA-RV, especially RV, is when the RV starts to fail, the RV and diastolic pressures rise and the intraventricular septum moves into the LV in diastole, which increases the LVDP also and perpetuates the tricuspid regurgitation further. And it leads to dilatation of all the four chambers. This phenomena is known as the restriction dilatation syndrome. This is another case of torrential TR, where you can see non-coaptation of the leaflets. The PA pressure is just 10, so it's a low pressure severe TR. Annulus is about 4.2 centimeters, so significantly dilated in end diastole. You have a secondary, so this is another case of biatrial enlargement in a case of atrial flutter with the both atria dilated. You can see the atrial flutter waves in the mitral MIP in this case. And this is the significant mitral regurgitation also, which you can see in this case. The TR is also significant. You can see there is moderate tricuspid regurgitation, and there is PA pressure of about 27 with annulus of around 3.6 centimeters. So between the secondary ventricular and atrial, you see tenting in the ventricular TR, while hardly any tenting in the atrial secondary TR. The annular remodeling is much more in the atrial TR as compared to the ventricular one. And RA dilatation, atrial fibrillation and flutter is more common, while RV remodeling is much more in the ventricular secondary TR. So this is some of the ways you can distinguish the two. Now, for TR, I'm going to just take a couple of slides on TR. So if you look at, these are the four essential views. You have the RV inflow view and parasternal long axis view. You have the short axis view at the level of aortic valve. You have the four chamber view, and then you have the subcostal view. So these are your four essential views which you should use for assessment of the tricuspid regurgitation. And what you look for is the color flow jet area, the vena contracta width, the continuous wave Doppler jet for TR velocity and PA pressures, RV systolic pressures. And then you also have to quantitatively look at the PISA and quantify the ERO and the regurgitation fraction, and a supportive assessment through the hepatic vein flow with systolic flow reversals. So for example, in this case, you can see the vena contracta. So this is an older classification. The newer classification has changed. So severe here is the vena contracta is more than 7 millimeter, large flow conversions, dense triangulated tricuspid valve flow with low velocity here. And there is rapid, so like a dagger shaped rapid ventricularization of the RA pressure. So we started seeing that a lot of these patients of severe TR, the older classification was not enough in terms of defining the severe category of TR. You needed more category to define even the severe TR. And that's when you had the massive and the torrential TR come into the picture from 2017 onwards. And you can see that now in the new classification, Anybody who has a vena contracta width of more than 14 millimeter to 20 millimeter is considered massive TR, and anybody with more than 21 millimeter is considered torrential TR. You have the effective regurgitation orifices. So severe was between 40 to 60 millimeter square. Now 60 to 80 is massive, and more than 80 is torrential TR in EROA, and regurgitation volume of more than 60 is to 60 to 74 is massive, and more than 75 is torrential TR. And this is another grading which was based on the 3D vena contracta area, and again that has been added in massive and torrential TR. So this is an example of vena contracta being showing massive TR, severe TR of 7 millimeter. Here you have 13 millimeter, more than 14. Yeah, you can just look at this again. So if you have more than 14, you will have severe, massive TR. If you have more than 21 vena contracta, it is torrential. So I'll show you an example of torrential TR. This patient had non-coaptation of tricuspid valve leaflets. And this you can see severe TR here, almost like a laminar flow. It is so large. The vena contracta was 21 millimeters here. And the TR, the EROA was around 1.35 centimeters square, huge ERO. So more than 80 is considered torrential, and regurgitation volume was also 84. So if you go back to the classification of severe, massive, so more than ERO more than 80 and regurgitation volume of more than 75 is torrential TR. So if you go back to this case, you had vena contracta of 21, you had an ERO of 135 millimeters square, and TR volume of more than it was 84 ml, so more than 75. And of course, there are additional information which you can go in for in terms of RV volumes, fractional area change, RVEF, strain, etc., which is not part of this discussion. And of course, IVC is important. So based on the IVC diameter, you look at whether it is collapsing or not. You can gauge the CVP. The one word about the TR jet. So you have to, what you obtain is the RVSP from the TR jet based on the 4V square, the Bernoulli equation. So you get this kind of a trace, and the peak of that will give you the right ventricular systolic pressure, to which you add the RA pressure based on the IVC. And if you look at the same way where you look at the PR jet to obtain the PA and diastolic pressures, if you want to take out mean PA pressures, there are many options, many equations which have been given. Like for example, based on the RA pressures, you can look at the peak PR pressure and add RA pressure to it. Like this one, you can have 1/3 of systolic PA pressure with 2/3 of diastolic pressure. PADP can give you a mean pressure. You can trace the TR jet and it will also give you a mean pressure. And this is another equation with for obtaining the mean pressure. But these are not that accurate in severe pulmonary hypertension. PVR assessment can also be done based on the peak TR velocity and the RVOT VTI by this equation, which has been given on this screen. So moving last slide on tricuspid stenosis, it has not been dealt very much in the literature. The pressure half time which you obtain through the tricuspid valve, if the pressure half time is more than 190 milliseconds, it is considered severe TS. If the calculated area is 190 divided by pressure half time, and the less than 1 centimeter value is suggestive of severe TR. If you look at the mean gradients of more than 5 across the tricuspid valve, they are also suggestive of severe TS. This is an example of both MS and TS, which is what is most commonly seen. This is a 3D picture of MS and TS. And these are an example of significant tricuspid stenosis. Thank you.
Yeah, thank you so much, Dr. Vinayak, for an excellent presentation, as expected, on tricuspid valve. So we will move to the last presentation now, and for that I request Dr. Rahul Mehrotra. He will be speaking about role of echo in guiding valvular interventions in the current era. and then we will take some questions from the audience.
Thank you, Dr. Manish. Thank you, Glenmark, for this invite and including me in this program. I'll be talking about echocardiography and its role in transcatheter valvular
Dr. Rahul, sir, sorry to interrupt. Can you be a little louder, sir? The voice is a little low.
Sure. So structural heart disease interventions are becoming commoner by the day and becoming more and more sophisticated. Accurate planning, placement of the device in question, and monitoring throughout the procedure is required. Besides, we need to be very carefully selecting these cases beforehand because these are usually very expensive procedures and the cost has to be borne. So before deciding about the success of the procedure, very high quality imaging to ensure that the procedure will be successful needs to be done. So fluoroscopy and angiography are imaging modalities which are used in valvular disease to some extent in different steps. But in intervention, we are hardly using them because of the problems like radiation, the requirement of dye, which is likely to affect the kidneys. And besides, very importantly, that we are unable to view the tissue, myocardial tissue, the pericardium, and the valve leaflets, which are very thin structures, in any detail with fluoroscopy or even angiography. Besides, CT, MRI is completely impracticable. Their utility inside the cath lab during the intervention procedure is not feasible. Besides the cost, the radiation exposure with CT, and practical limitations with the use of MRI in the cath lab. So that leaves us with echocardiography for guiding the procedures during the intervention in the cath lab. So this is just a picture which is speaking louder than word. Here is a T probe and here is a fluoroscopy screen. You can see a mitral clip device being taken in, but you can hardly see any part of the mitral valve, interventricular or interatrial septum, etc. So we don't know where in space we are located, except for guessing. And this is a one image which speaks again louder than words. A bicable view showing a very difficult septum. It's like rotating with every heartbeat and we have to cross this septum, so it is likely to be very difficult. And the interventionist can beforehand look at this image and understand the difficulty likely to be encountered and plan accordingly. So one simple image in no time, giving a huge amount of information, very useful for the procedure. So echocardiography has its unique advantages in terms of being completely non-invasive, very versatile, extremely safe, quite accurate in terms of determining cardiac structure and function. And of course, it is mobile and real-time imaging is possible. We have machines as small as those fitting in the palm to as large as requiring a complete room. But all these information can easily be provided by the different modalities of echocardiography that are available on this machine. For example, if we talk of echocardiography in transcutaneous edge-to-edge repair, for the mitral as well as tricuspid valve, which is becoming popular nowadays and is completely changing the scenario of patients with mitral and tricuspid regurgitations who are otherwise inoperable and had very little chance of survival. So echo in these situations is very easily providing us with all the information required to predict the likely success of this procedure, plan the procedure in details, because we acquire precise information related to the structure, the chamber sizes, the type of interatrial septum, hemodynamic pressures. Dr. Vinayak showed the different categories of tricuspid regurgitation and different parameters to be measured for precise assessment of severity of TR as well as the type of TR, which is very important to decide about the procedure in question. So all this has to be determined by echo and no other modality fits in this position. So this is a few pictures showing a precise measurement for MTR, for example. We are able to measure the coaptation gap, the regurgitation orifice where it is coming from, an end-fast view of the mitral valve in relation to its neighboring structures, clearly showing what a surgeon sees after opening the left atrium. So a visual picture which is very descriptive and very useful for the interventionist to decide about the procedure. So echocardiography, while helping in the intervention, is required at all stages of intervention. For planning the intervention before a patient is deemed suitable or unsuitable for a particular intervention percutaneously, we need to do echo to select the patient to decide about the timing of intervention. What Dr. Rishikesh showed today was largely about the timing of percutaneous, say, aortic intervention, whether the patient we are already late, there is no stroke volume reserve left with us, or we are in time and the procedure is likely to be very successful. Similarly, during intervention, for some of the interventions, echo guided imaging is completely indispensable, and these interventions are just not possible without the help of echo during the procedure. After interventions, also follow-up echoes are done to see the residual effect or success or any residual problem left behind after these interventions. So echo is the modality to go to for percutaneous valvular interventions, and that is why there is a resurgence of the requirement of echo in valvular heart disease, not only before assessment of severity, assessment of etiology, mechanism of valvular diseases, but now during percutaneous interventions also echo is an indispensable tool. So when we talk of echo, the two modes that we commonly use are transthoracic, transesophageal. We've seen during this session a mix of different images having their own set of utilities. But overall, during interventions, we require transthoracic usually during planning of the intervention, while transesophageal is utilized at the time of intervention in the cath lab to guide the intervention in a very systematic way. Intracardiac echo is also a modality of echo which produces imaging from inside the cardiac chambers. Currently, not widely being used for different reasons. Most importantly, it requires vascular access. Completely new amount of training will be required to understand the images and the views that are formed. So currently, very few places in the country have this available, and the interventions are largely being guided by transthoracic and transesophageal echo. So these are a list of percutaneous interventions where echocardiography guidance is being utilized. The right side of heart as well as the left side of heart, all the valves are being utilized, being assisted by percutaneous intervention, and that is being done with the guidance of echo. TAVR is mostly now being done without echocardiography, but pre-procedure planning to assess the severity of aortic stenosis, whether it is likely to be successful, the degree of calcification, etc., to some extent is assessed by echo, but CT is important. But during and after TAVR, we do require echocardiography in the cath lab to look for para-device residual regurgitation and guide the success. Also for troubleshooting complications like when valve rupture happens sometimes, pericardial effusion, which can be immediately picked up by echo imaging, is utilized in the cath lab even for TAVR. For other procedures, it is for almost all the steps that is still being utilized different modalities of echocardiography. Coming to a word about 3D echocardiography, it is not just echocardiography which has revolutionized the percutaneous intervention. It is the 3D echo which has added a new dimension literally to this imaging which we are using for transcatheter valvular intervention. 3D has rapidly become the gold standard for different aspects of echo, like determining LV volumes, mitral valve anatomy, severity of mitral stenosis, tricuspid valve anatomy. Dr. Vinayak showed some wonderful images, and for guiding of transcatheter procedures. So all this is largely being driven by 3D and largely by 3D transesophageal echo. This is because 3D provides excellent image quality. In a single frame, you can see biplane or even multiplane imaging is possible. Online spatial orientation of different structures in relation to each other is very clearly demonstrated. On-fast display of structures is possible so that you can clearly see the entire anatomy in one picture. A very important aspect is that the guide wires and catheters, which were by 2D echo are seen as dots, are seen as entire structures which are blown out of proportion. So they are very clearly seen, and enlarged view of wires and catheters is made possible, which is very useful during the procedure. So coming to a few examples of all the three stages where echo is utilized. This is for rheumatic mitral stenosis. We require 3D echo for a precise assessment of severity because this is the best way to assess mitral valve area, the planimetry exactly at the tips of the mitral leaflets. The current gold standard is 3D echocardiography. And we also require to assess the success of percutaneous balloon mitral valvotomy if it is planned. And usually it has been done by Wilkins score. But we know that there are several limitations associated with the Wilkins score, particularly the most critical area, the commissural morphology, is not included in the Wilkins score. And now, understanding this limitation, a 3D score has been developed, which is widely shown to be more accurate, more uh, predicting success, and also predicting the lack of success. So we do not go ahead with these procedures if we have a poor score on 3D echocardiography. And it is quite feasible, easily done in very little time. Similarly, for atrial septal defects, device closures have become the standard now. Wherever feasible, wherever possible, it is preferred over a sternotomy or an intercostal incision to do this procedure now. But we have to be very sure whether it is going to be successful. The rims have to be looked at, the size of the defect has to be carefully measured and predicted. So here is an example. Not only this, that we could measure the size, we could see that this was a fenestrated defect, multiple atrial septal defects. So clearly device closure was ruled out. The patient was taken up for surgery and the surgeon gave us this image, which was an exactly similar image which we had seen pre-operatively before, not before even opening the patient. So very clear description of anatomy, very clear procedure planning is made possible because of this information. In the current era where mitral transcatheter edge-to-edge repair is becoming very popular, there is a large number of parameters which need to be measured. And based on these echocardiographically measured parameters, it is decided whether the procedure is likely to be non-complex, ideal for MTER, or it is going to be a very complex and challenging procedure only to be done in expert centers, or we completely rule out MTER, a very expensive intervention for these patients, and guide them that it is likely not wise to proceed. All this information very easily determined by good quality echo and transesophageal. For all the left-sided interventions, we need to cross the interatrial septum and go from the right side to the left side, which is a key step in predicting the success of the intervention, saving time, landing in the right zone in a very short period of time. So the septal puncture has to be done in different locations of the fossa ovalis. Very easy to look at, but when you look at the fluoroscopy screen, where is the fossa ovalis? It is only to be guessed based on different anatomical landmarks like a pigtail catheter lying in the coronary cusp of the aorta, different wires going in different locations, and we imagine the location of a fossa ovalis and then do this very critical step. All this is very dangerous, no doubt. Very close to aorta, you can land up sometimes rupturing. So all this has been made possible only by the use of transesophageal echo, 3D transesophageal echo, which gives us a biplane image of the atrial septum. Superior inferior orientation is possible by bicable view, and antero-posterior orientation by this orthogonal view, where we can very clearly plan the puncture site, whether we are posterior and inferior or superior and posterior. All this can be very clearly seen by the interventionist. So the site of the puncture can be very carefully and precisely determined by the use of this imaging, which is possible only by 3D transesophageal echo. Very clear imaging is made possible. So all these left-sided percutaneous interventions require this septal puncture to be done, and all this can be done only under 3D TE guidance. Very precise puncture. Once the puncture is at the right location, rest of the task becomes quite easy. During intervention also, almost all the percutaneous left-sided intervention require continuous 3D transesophageal guidance. This is an example of paravalvular device closure being done. And the critical worry is to not to take our guide wires or catheters in this metallic prosthetic valve. So if perchance our guide wire enters this prosthetic valve, metallic, you can imagine the damage it will do not only to the wire but also to the valve. And we have to be sure that we are passing out of the annular ring. So here you can see, because of the blooming artifact created by 3D, we can see that the wire is clearly outside the ring and the interventionist can safely proceed with the procedure. So very successfully this plug was placed and paravalvular device was closed because of precise 3D guidance. This is again after balloon mitral valvotomy, something that was done under fluoroscopy guidance, but required a lot of imagination and lots of experience for the right location of septal puncture. But now most interventionists are happy doing this procedure under transesophageal guidance. Immediately we can see whether commissures have been torn as required or not, whether the MR severity has increased substantially or within limits. Similarly, for ASD device, we can guide whether the device has been placed in correct position, enough area of septum has been grafted, there is no chance of embolization. Very clearly, we can see the two discs on different sides of the septum. So safe deployment has been dictated. Even for TAVI, we can demonstrate immediately the para device regurgitation if it is occurring. This 3D image is clearly showing the two discs on two sides of the very thin intraatrial septum. Cannot imagine seeing this in any kind of fluoroscopy or angiography. There are lots and lots of limitation of these, and as we advance, more and more of these interventions are happening. These limitations are being overcome. For the interventional cardiologists who have traditionally been trained only on fluoroscopy screens and angiography screen, they are not oriented to echo images, the different echocardiography views and different structures seen in different images. They need to learn the echocardiographic views and images and speak to the echocardiographer what they require. So they have to do their learning. We as echocardiographer, when we are in the cath lab, we are in a very awkward position because often we are treated as a foreign object. But now we are indispensable. We have to be there throughout to guide the procedures. So very little space is usually available towards the head end of the cath lab for a large echo machine, and we are often in a very awkward position to manipulate the T probe, the buttons, and often the slave monitor is not available. So we have to be telling the interventionist to look at the echo screen again and again and tilt the echo screen in their direction, etc. And also we have to be very careful about the different new kind of artifacts that can be produced in the 3D image by the injection of the contrast, by cautery sometimes when it is being utilized, by electrical circuitry which is present throughout the cath lab. So we have to be also modifying our views, our imaging, our position. Not so comfortable, but we have to be learning those things, adapting to the situation. At the institutional level also, an echo machine is usually required for these procedures in the cath lab for extended duration of time. The routine OPD procedures are usually to be halted during that time. Backlogs happen, angry scenes are there in the OPD, unscheduled calls from the cath lab. All these have to be carefully planned out. If possible, a separate machine for the cath lab is to be provided by the institution. A key echocardiographer, once he or she is absent, present in the cath lab, OPD work does not suffer. So provisions have to be made for all these. So these are the certain limitations which have to be overcome as we progress. Another interesting development happening is fusion imaging, which is superimposition of echo images and the fluoroscopy images. So we can clearly put landmarks. For example, here the precise location of septal puncture has been marked by a pink dot, which is projected on the fluoroscopy screen. So the interventional cardiologist can just utilize this dot and know that this is where the interatrial septal puncture is to be made, and he can target without looking at the echo screen on this particular dot. Similarly, echo images can be superimposed on the fluoroscopy screens so they can understand better by this echo navigator tool. So to summarize, structural intervention cardiology is a rapidly emerging field. Echocardiography is indispensable imaging mode at every stage of the procedure. There are certain demands in the cath lab which needs to be met, which are fulfilled quite nicely by three-dimensional echocardiography. Is very useful in this, and future innovations in the field of imaging are likely to make this modality even more useful and more precise in delivering these interventions. Thank you so much.
Rahul, for this very nice presentation. And I thank other speakers also for very nicely covering the topics. Now we know we have already overshot our time, but we will quickly take a few questions. So the first question is for Dr. Rishikesh Shah. And the question is, how DSC help differentiate true severe AS from pseudo severe AS? I think this question came much before you finished your presentation. This was already covered in detail, so I think we can skip this question. The second question is for Dr. Deepika Chatterjee, how to avoid patient processes mismatch?
Yeah.
You told about how to assess it, but the question is how to avoid it.
How to avoid it. So, patient prosthetic mismatch usually happens in the aortic position, especially in a female patient where the body surface area is very small. So, actually, we have to have the proper selection of the prosthesis size, and for that, accurate measurement of the aortic annulus is very important. Now, by two-dimensional transthoracic echo, when we measure the aortic annulus, we measure the anteroposterior diameter. And actually, aortic annulus is oval in shape, where we don't measure the side-to-side diameter. And that can be done only with the help of three-dimensional echo. So we have to use three-dimensional echo and also the CT. MDCT is the ultimate answer of accurate measurement of the annulus. If it is small, because of the smaller body surface area, the surgeon does the widening of the annulus often, and also the present generation prostheses are much better. Those are self-expanding, and over the annulus, the surgeons place the thing. But while measuring the annular size, we have to be very, very careful. We have to measure from hinge point to hinge point in two-dimensional echo, and we always should use the three-dimensional echo. And of course, it is the CT scan which will measure the accurate size of the annulus. So if we select the proper prosthesis, there is less chance of patient prosthesis mismatch.
Yeah, very correct. So accurate sizing is important. And as you mentioned, if we anticipate PPM, then there are some options like aortic root enlargement, which some surgeons do routinely. Most others don't do it in India, at least. The other option would be to go for a bileaflet mechanical valve instead of tissue valve, because bioprosthetic valves give a smaller size. Then supraannular placement. In young individuals, we can think of Ross procedure. And on the other hand, in elderly patients, we can go for TAVR instead of surgical area, because TAVR gives a bigger valve area. So all these options are there to avoid patient processes mismatch. But all this starts with a very accurate assessment of aortic size and anticipating what size of valve will go into that person's aortic root. Okay. So the next question is for Dr. Vinayak, and the question is, in a patient with severe TR and preserved RV function, what is your guidance regarding management?
That's a very important question, because we have to understand that the treatment or management of choice will always be medical therapy first. So in a preserved RV function, we should not think about, say, tricuspid. So if it is a left heart lesion, like what Dr. Rahul was showing, somebody having mitral stenosis with pulmonary hypertension, we will treat the left-sided lesions, try to better manage the left heart lesions if we can. If it is an isolated tricuspid regurgitation, then we know that the mortality with TR isolated surgery is high. It's about 12% or so. So the first, in a preserved RV function, you should not go for surgery or any intervention at all. In fact, the best strategy in these cases will be to medically treat them. Most of the times, diuretics is what we are giving. And if they have atrial fibrillation, they have, rhythm can be optimize in these cases, then that can help. Like yesterday, we did a case of atrial flutter ablation in a patient who came with, atrial flutter with severe RA dilatation, RV dysfunction, TR. And after ablation, the patient's TR almost diminished by half. So, and is likely to improve further. So you have to look at the patients. But if the RV function starts to fall, the other point here I would like to make is you'll have to look at the etiology. For example, if the patient has pulmonary hypertension as a cause of severe TR with preserved RV function, then you look at the evaluation of the pulmonary hypertension, say which type of pulmonary hypertension it is. If it is type 1, then you look at pulmonary vasodilators, etc. If, on the other hand, you feel that the patient has ongoing RV dysfunction by echo and other parameters, that's when you start looking at either a repair or replacement. So if there is a decent, durable, say, RV reduction, which you can give to the patient with RV repair, with annuloplasty, D Vega is not considered very good, then you do that. Don't go for a valve replacement as such. In case it is unlikely, no sort of surgeries can be done, that's when you should go for transcatheter interventions. But there also you have to be understanding that if there is an ICD lead which is interrupting the procedure, if there is severely impaired RV dysfunction already, if there is high bleeding risks, or patient is on dialysis or liver dysfunction, etc. So, or they've had an infective endocarditis, etc. These will be potential red flags for the transcatheter intervention. So I think it is pretty much tailor-made depending on what etiology we are dealing with.
So now the next question is how to prevent, I think it's for Dr. Rahul, how to prevent pre and post procedural complications TAVR. So pre, I don't think there will be any pre-procedural complication. It has to be only post-procedure. So how to prevent post-procedural complication in TAVR? So how echo could play a role? I think that's what the intent is behind this question.
Yes, so while we are doing echocardiography of a patient with severe aortic stenosis, apart from the assessment of severity, nowadays the patient going in for procedures like TAVR, we should always carefully look at the LVOT, the automitral angle. These aspects very important for predicting, because there could be some unique problems like SAM developing sometimes if the procedure is not done properly. Calcification, wherever noted, should be commented upon so that the interventionist is aware of excessive amount of calcium present. And this will be told very accurately by CT, but as an echocardiographer, we should always give these reports from our side. Accurate measurements are very important for LVOT, annulus, sinotubular junction, ascending aorta. Any plaque noted in ascending aorta, calcification should be commented upon. So a good quality echocardiography report routinely should be able to give enough information to the interventionist to anticipate certain problems beforehand and choose the correct device, type of device, balloon expandable versus self-expanding, and whether to go ahead with the procedure with the available information or not. So rather, other than doing a detailed echo of the aortic valve, I don't think there is anything specific we need to tell in terms of TAVR.
I think that's correct. So I believe these were the only questions that we had from the audience. So I will once again thank all the speakers for doing an excellent job with the topics that they were assigned. And I hand it over to Dr. Navya once again.
Thank you so much, sir, for a resourceful and a fabulous session. And for delivering the vote of thanks, I would like to call Mr. Anil from the marketing team to address the gathering.
Thank you so much, Navya. On behalf of Glenmark, I really want to extend my heartfelt gratitude to all the esteemed speakers, Dr. Manish Bansal, Dr. Rishikesh Shah, Dr. Deepika Chatterjee, Dr. Vinayak Agrawal, Dr. Rahul Mehrotra, and of course, Dr. Shantanu Sen Gupta, for sharing their valuable knowledge and clinical insights today. Last but not the least, Dr. Mahesh Bansal for excellently moderating the sessions for all of us. A special thank to all the participants for your active involvement and engagement, which made this program truly enriching. We deeply appreciate your time and contribution to advanced learning in 2D eco techniques. Thank you once again, all, and we look forward to meet you in our next session. Thank you so much, and good night.
Thank you and
Thank you,
Thank
everyone.
you very much.
Thank you.